Alrighty, so today is the first Beer and a Thought podcast episode video thing. Not sure quite what it's going to turn into yet. Pretty much the idea behind this is that I'm going to have a beer and my guest is going to have a thought and we're just going to talk about it. So it's really meant to try and get people to share their experiences, share some research that maybe they're doing, expertise or clinical pearls, and kind of anything that they feel is worth sharing. So today, our first guest is Dr. Tim Reynolds. He is a clinical assistant professor at Ithaca College, and he is also a part-time physical therapist at Cayuga Medical Center. He is orthopedic residency trained, spine fellowship trained, and he's got a few publications to his name, and today we're going to be talking about one of them. So, Tim, I don't know if you want to give a different introduction than that, but I'll hand it off to you.
I appreciate it, John. My name is Tim Reynolds. I was an Ithaca College graduate back in class of 2014. I did a residency in orthopedics at Cayuga Medical Center and then continued on to do a spine fellowship there as well. Been teaching at Ithaca College since 2015 and recently got hired for a full-time position to teach anatomy physiology at the college. Really excited to have the opportunity to talk. Looking forward to seeing where this goes.
Me too. It's the first one, so we'll get a flow going, and I'm excited to see where it's going. I think we have a good topic picked. So Tim, what's your thought? What's your thought that you're bringing into the episode?
Yeah, so I think one of my biggest, skill sets that I learned during my postdoctorate training, residency gave me an opportunity to learn a lot about how to master the orthopedic clinical setting. And I learned a lot of good, valuable skills. And then when I went into fellowship, I think the focus definitely narrowed in. And one of my mentors was Jason Cherry, who you know, obviously. Yep. And Jason really opened my eyes up to how our words can influence our patients and their clinical outcomes. Whether that be through motivational interviewing or at least just mindfulness with our word choice. And so over the last couple of years, I would say in my clinical practice, I treat a lot of patients with spine pathologies and a good portion of those with persistent pain or high fear avoidance. And so a good portion of my practice over the last couple of years has been, how do I communicate with patients and how can I pick and optimize my word choice in order to set them up from a success standpoint and either reduce fear or at least give them better clinical outcomes. And so today's thought would be the power of words. So.
All right. I love that. And for anybody that knows me, they know I have a strong interest in psychology and a little bit of a background in sport and exercise psychology with one of my minors. And of course, motivational interviewing is a big part of that. I was also taught by Jason at IC, and I remember one of my first real clinical exposures to it was in a rotation in the clinic on campus with John Mayer, and he was really big on using patient first language and really being very consistent with using that, and that was like my first clinical exposure to it. So I'm excited to see how somebody who's been out and practicing and has some extended training and incorporates it into their practice. But I think it's a great topic, and hopefully we can have a great discussion on it. So. Yeah,
no, I'm excited. And I think it's one of those things that I'll listen to a lot of our residents as they come in and just the words that they choose and whatnot. And I think that's definitely part of the physical therapy game that takes a lot of practice. And I think it's one of those things that definitely repetition can really prove beneficial, not only from a hands-on skill set or exercise prescription, but being comfortable how you phrase certain concepts with patients can take a lot of practice as well.
Mm-hmm. So I just a week or maybe 2 weeks ago, I posted a video about using patient first language because I feel like that's a very easy way we can kind of start to use our words. And I mean, you're more with the orthopedic population. I'm more with the neurologic population. And I know with the neurologic population, once they get these conditions, they're generally for life. And,
right.
A big part of using patient first language is, these patients have repeatedly been to doctors and rehab techs and all that kind of stuff. And if they're just constantly referred to as, the spinal cord injury, it can have a huge psychological effect. So Could you talk a little bit about, using patient first language, and then maybe kind of expand a little bit further into what you've experienced with that?
Yeah, I think that's really valuable because I think when we're going through physical therapy school, everything's a case, right? 16-year-old female with patellofemoral pain walks through the door. And so we associate pathology with this patient's identity and not necessarily having the opportunity to appreciate who is that person, what other aspects of the psychosocial health do they have, or do they contribute to society? And so I think one of my biggest components of my clinical practice is my lack of pathological word choice. And so obviously, depending on the demographic and depending on the person themselves and what they're looking for from a practitioner standpoint, I use a lot of metaphors when I talk. I use a lot of words like sensitized or load tolerance or tissue issue, just ways that I can sort of dance around the subject of what's potentially the contributing factor in regards to their symptom generation, just because 90% of the time we don't necessarily know. I mean, we can look at some of the literature from a low back pain population standpoint and say, even with MRI imaging, there's a pretty good chance that we can't necessarily say that is the tissue that's causing the issue. And so I think when we're thinking about patient first language, we have to be mindful with giving them a diagnosis that they're going to potentially take to the grave with them, right? They have this label that they've been provided. And a lot of times, certain practitioners may not necessarily have either the mindfulness component, or they just don't have the time. They have to just give the answer to the patients. They can't necessarily explain things in such detail. And so the one thing the patient holds on to is degenerative disc disease, or you have stenosis. And so that language is now their identity. And as they're walking out of the door, they might not necessarily hear anything else that you said about the prognosis or the treatment plan. But when they go home to their spouse or their loved one, they say, yeah, I just told I have stenosis. And my grandmother had stenosis and she ended up in a wheelchair. Mm-hmm. And so that's where that cascade of psychological turmoil has the opportunity to sort of grow. And so I really try to think about how best can I provide you with the necessary education for you to walk out of the door that you feel like you're not necessarily gypped. Because I don't want to just be blowing smoke at people in terms of like, well, I'm not just telling you what's going on, but at the same time, I want to make sure that I can educate you about not necessarily what's going on, but these are the steps that we're going to be taking to get moving in the right direction. Mm-hmm. And to me, that's what patient first language is all about. Empowering the patients that they walk out of the door, they can explain exactly what's going on in their own language. Because that's the language that I'm using for them. So, yeah.
You said a lot of great things there, and I want to unpack a few of them.
Sure, go for it.
So one of the things you said, we'll kind of try and go in order here, is you said that maybe their practitioner, PCP, or whoever they saw before they came in to see you didn't take the time, and they kind of just threw in that language of here's what the issue is. Do you think that taking that extra time and maybe seeing one or two less patients would have a greater impact throughout the lifespan or of their condition? Or do you think it's kind of one of those things where that falls more on us?
So I think that's where I had a patient the other day, actually, a 72-year-old female who I've treated in the past, put on my schedule 2 weeks out. It's typically our wait time right now. It's 2 weeks for an evaluation. I received an email saying, please call this patient. They say it's an emergency. And they had an exacerbation of low back pain with radiating leg pain. But they were told by their primary care physician, go to the nearest hospital, go to the ER, if you ever want to walk again. And then the subsequent advice was just stay in your recliner because that was a position of comfort. Mm-hmm. So for 2 weeks, this patient's been in a recliner, afraid to walk because they might not walk again. So I called the patient, and And they said, well, do you think I'll be able to return back to my normal lifestyle? I was like, yeah, sure. We're just pissy tissue right now. It's just kind of hot and bothered and a little irritated, but like, we'll find a way to desensitize it. We'll get you back moving in the right direction. Oh, okay, that's such a relief. But for 2 weeks, as patients had this sort of this cloud over their head in terms of what's going on. But I do think that's where that mindfulness approach of what is the patient gaining by instilling that level of concern. Now, granted, and in a paper I recently just submitted from a clinical Pearl standpoint, I do mention that it's necessary at times to talk about pathology, because not everything is sunshine and rainbows. And so with this patient, as they come in from a subjective standpoint, I'm asking, do you have any bowel or bladder changes? Do you have any saddle anesthesia? Do you have any signs of potential cardiac decline that might give me a bigger concern or red flag that I have to send you to another physician that will be able to take care of it? But that being said, is it potentially more fear-inducing, and every time that patient starts to experience that leg pain in the future, I tell people that back pain's like biting the inside part of your lip. You never know when it's going to come, but it's going to be recurrent. But just like biting the inside part of your lip, it's going to heal, right? And so you don't live in fear of chewing. You go on with your life, you continue to eat, but you might just need to eat on the other side of your mouth for a couple of days as that tissue desensitizes and you get back in action. And so I think every time this patient now feels that onset of potential nerve pain, there's going to be a figment of their imagination that goes to, I might never walk again. And so I do think taking that time to slow yourself down, think about what words or what alternative words could be utilized, that from a synonym standpoint can still provide the same quality education to the patient, but just the way you spin it and the way you approach it, I think would, one, reduce their utilization of extra healthcare dollars, right? How many follow-up medical appointments is this patient going to have if they're at a high fear point avoidant level initially, versus if they're told, yeah, this is a common situation. You're looking at like maybe 8 to 10 weeks from a clinical course standpoint. But this is the game plan. This is the action plan. They're probably not going to be on the phone every time they're starting to feel an exacerbation of their symptoms. And so I think the extra time would be valuable, but that's where, thankfully, with our profession, we have the time and the resources and the knowledge and the education behind providing some of that education to the patient, where the practitioner that does the referring might just need to screen red flags and get them to us as soon as possible. And so would it be nice if they could potentially at least plant that seed, or better yet, not necessarily plant the wrong seeds that we have to undo at the subsequent appointment and then spend time sowing new plants. So it's definitely an interesting part of the game, but I do think that taking the time in the beginning and establishing that patient first language and establishing that relationship will allow for a better, course of clinical outcomes in the future.
How much of a role do you think us as physical therapists play in educating our colleagues, not only other physical therapists, but other healthcare practitioners who maybe don't get, I don't know what other healthcare practitioner schooling is fully entailing, maybe don't get the education, or they don't get as much of an emphasis on it? Because I feel like with PT education, we get a lot of, patient-centered. And a big part of that is patient first language and, the power of our words. But do you think other healthcare professions get that same amount of schooling, or because they're on that more medical side, or do you think that's something that maybe we have as a profession kind of have to take ownership of and try and pioneer and educate others on?
Yeah, and I'm sure that other health professionals have some level of either a mindfulness or cultural competency or some other, we'll say, soft skills training. But even when I was like 16 years old and I said I want to be a physical therapist, I sort of made up the mindset that 80% of being a PT is your ability to talk to somebody, right? I mean, you could have the coolest exercises in the world, but if you're walking through that door and being like, geez, I got to go to PT today, that patient's not going to have the best experience. And so I do think that our profession in itself, we are the movement specialists, but we also wear multiple different hats. And I think one of those hats is going to be a patient advocate and a healthcare advocate in terms of how do we best prevent all these unnecessary utilization of healthcare resources, whether that's excessive MRI or imaging, opioid medication use, unnecessary follow-up appointments, right, or surgical consults. And so I think our role, we start that paradigm shift in terms of how we're educating the patient or how we're communicating with the patient. Hopefully that does transfer over into other professions as well. We have a professional lecture series through Cayuga Medical Center. And back in December of last year, I had the opportunity to present on this topic, the power of words. And I think it was great because we had multiple disciplines. We had sports medicine there, we had athletic training there, we had general practitioners there. And I think my goal for the day was walk away with one or two on Monday morning, what are you going to do? Kind of thoughts. And so, for instance, like from a radiological standpoint, mentioning, do you include what are normal findings in specific demographics on the MRI report? Right. So that when you are 30 years old and you see degenerative disc disease at L4, L5, L5, S1, you can say, well, yeah, 40% of the population at this point should have some level of tissue changes there. Right. Versus saying that is the reason for your pathology. Or doing something instead of using the word pain, using the word symptoms, right? And it doesn't seem like that significant of a change, but every day when I walk into the clinic or every new encounter, I slow my thinking down just a little bit so that what's your pain today? Or I could say, how are your symptoms? Or does that reproduce your symptoms? Because the word pain itself has negative connotations associated with it, right, whereas symptoms is less threatening. And so I do purposely try to pick less threatening words. And if other healthcare professionals could start to implement that, instead of saying that's the worst arthritis I've ever seen, or like, you're going to need a new knee replacement in 4 years, or the other knee is going to go in 4 years. You're instilling these elements of fear, which we know from a clinical research standpoint is very detrimental in terms of pain processing, tissue healing rates, right? I mean, I think my favorite piece of evidence was this one study done with dental students. I don't know if you've heard of this one. And so what they did was they took, I believe, 12 students, and they took a punch biopsy on the roof of their mouth, and they wanted to track to see how long does it take for that tissue to heal. And they did it on the first day of summer vacation, and then they did it 3 days before the first big exam for the semester. And they saw 40% slowing in the tissue healing 3 days before that first big exam because of the physiological stressors that take place in the body. And so you combine that sort of research in addition to, well, what part of the brain is activated when people are reading pain or threatening word choices? Right. And it's the same part of the brain that's activated when they're actually in pain. So reading the word degenerative automatically kicks on that part of your neural system. Right. You probably speak to this better than I could, right? And so they're going to be able to start to already get that signaling. And I think you're just adding fuel to the fire when you are throwing these words out to patients and not using patient first word choice. So.
Yeah, that's really interesting. I hadn't heard of those studies until I read your recent publication, The Power of Words. But that kind of, it brings me or makes me think of an interesting point that I've kind of just started getting a little bit more diving into. So recently I've been looking into a lot of the work of Dr. Lisa Feldman Barrett. She's a psychologist, and she's been doing a lot of work on emotion and kind of how our emotions are not hardwired into us, and there's no physiological blueprint for emotion for any humans, which is a very new way of thinking about emotion, because the more traditional way is everyone's born knowing that a frown means sadness. And a lot of her work is starting to talk about how emotions are generated within the brain, and you can have 100 people have a fear emotion, and they're all going to have a different brain pattern. And to me, so I do a little bit of work with some physical therapy students on working on diaphragmatic breathing for stress and anxiety reduction, and kind of educate them on some of the science behind that. But when I read the work by Dr. Feldman Barrett, kind of makes me think too, our ability to perceive words and perceive events and emotion allows us to regulate our response to those. And kind of like you were just talking about, maybe if we can shift that perception of their condition based on our words, we can avoid that fear emotion and maybe change it into a challenge emotion. And there's some research out there that looks at perceiving situations as threats and as challenges. And if all you do is perceive something as a challenge compared to a threat, your physiological responses are better, and your enhanced expectancies are also better.
Interesting.
Just expect yourself to perform better by thinking of something as a challenge rather than as a threat. And I'll put some of the articles that I'm thinking of down below. But so then if we can use our words, kind of how what you're describing, to change that perception for the patient as this is something fearful and painful, and I'm bone on bone. I think that was one of the things you referenced in the
right.
I can't say how many people, grandparents or whoever, they say I'm bone on bone, that's why it hurts. And if we just shift their perception on what that actually means, or shift their perception on it's not pain, it's just your tissue is having an adverse response to whatever movement you're doing or what position your body's in, then maybe we can shift more towards that challenge. I can do things to help my body fight this rather than as a threat, and also kind of change our perceptions on fear.
I think that's great. I mean, one of the pain science metaphors that I would utilize previously was this concept of taking a walk, right? I mean, if you were taking a walk in a nice meadow, the sun is shining, there's a rainbow, there's butterflies, everything's great. What's your physiological response at that point in time versus if you're taking the same walk, the same speed down a back alley at 2 a.m. in a neighborhood that you don't necessarily know about, and you hear some screeching in the hall, down the alleyway. What happens to your heart rate? What happens to your blood pressure response? What happens to your perception? And so just changing the context of the scenario, even though the physiological activity itself is the same, can play a world of difference. And so I think the idea of more of a challenge versus a threat is great. And so when I'm treating patients, I incorporate several key things to either my subjective or my examination flow. One of which being at the end of the subjective, I ask my patients either what's your perception of what's going on, or I'll phrase it in terms of like, you've been living with this for a while, you've seen multiple medical professionals. What's your gut say, or what do you think is happening? And it's really interesting to incorporate that level of communication, just because you'll be able to potentially catch yellow flags at that point in time in terms of, well, I think it's bone on bone, or they said it's full of arthritis and stuff like that. So that part of your education has to be directed at that level of perception and belief, or that is still going to be the perception and belief that they have when they walk out the door. Mm-hmm. And so I'll incorporate that at the end of my subjective, and I'll also mention for some patients, depending on how they sort of present themselves, what do you feel like you need to get moving in the right direction? Right. So once again, I'm giving you an open door in terms of your potential opportunity to make this a collaboration versus a patriarchal model in which I am the clinician and I'm providing the treatment for you. If you say, I think that soft tissue work and exercise is going to be really helpful, and I sit and talk to you for each treatment session, and I'm not necessarily giving you what you already perceive is going to be beneficial, then I'm doing a disservice to you. Or you can even go to the extreme of saying, well, I had ultrasound for the same tissue issue 3 years ago, and it cleared up right away. And I think a lot of new graduates and graduates in general, and we're all sort of guilty of this with modalities to an extent, we might be fearful from our own standpoint to utilize that because, well, the research doesn't show that there's anything beneficial with this, but we're forgetting those different aspects of the pillars of evidence, right? I mean, you got evidence itself, but then you have the patient's perspective on that and the patient experience, and that's almost as beneficial, if not more so. So I try to incorporate that, and then at the end, I use the idea of sort of a sandwiching of positives, negatives, and positives. And so I'll run through, and this is sort of my attempt at trying to continue with that sort of patient first, and the word choice that I use and how they leave the appointment. But these are all the positives that you can do, even if they're not necessarily relevant, right? So if their main issue was shoulder rotation pain, and we have a really good cervical range of motion, and these motions look really good, so you're sort of like fluffing them up as much as possible, so that they're walking out of there thinking, well, there's at least some positives with me, because especially with some of those patient populations that are dealing with persistent pain, and have been worked through the medical system multiple times, they probably walk away with each medical appointment with a new issue or a new thing to add to the list about why am I broken. But if you actually start the conversation with positives, you're going to catch them off guard because they weren't expecting that.
Yeah.
And then I transition into, this is what I think is going on, utilizing those patient first words of, you have your tissue's tolerance to this motion is not that good, so the tissue sensitized, but this is the game plan. And so I always try to finish up with, this is what we're doing to get you moving in that direction. And then when I was in fellowship, I got into the habit of sometimes asking the patient, so when you go home, what are you going to tell your loved one or your spouse about what we learned today? Because if they can repeat it back to you, you're once again going to catch those yellow flags. They said, well, you said my rotator cuff was torn. Like, I didn't really necessarily say that, but I do think that the tissue's tolerance might not be great, right? And so it's one of those things that there's so many small aspects of how you present the same subjective information in the same evaluation in the same treatments, that if you just perfect these and spend the extra 2 minutes or extra skill set of practicing those things, I think the quality of your care can increase exponentially.
Yeah, that's great. And I think it reminds me a lot of some major concepts within, neurologic practice in terms of saliency with neuroplasticity, putting that patient first. And even if it's like something simple, so like right now I'm in the acute care setting, and I had a patient the other day that we were working with. We were working on trunk control in standing, but she loved to cook. And I'm in the hospital room, I can't bring in like a spatula or anything. So we had her flipping burgers with like a little fork and like a hospital tray type of thing. But like, she totally loved it. And it brought in, it like gave her a little bit more efficacy, because I asked her like, what could we do to make this more fun, more interesting? Because just asking them to reach for your hand gets old after the first couple. And then I think it reminds me a lot of some of the work by Wolf and Luthwaite in terms of optimal motor learning, and what you kind of were talking about showing them what they are doing good, even if it's not anything really that has anything to do with their condition. And they actually did studies, and they looked at motor performance based on an enhanced expectancy for a task. And they looked at putting, and if you're putting, they had groups putt into a large hole and then groups putt into a normal sized hole. And the groups that putted into the larger hole, when they came back and were asked to putt into a regular sized hole, actually performed better, even though they hadn't practiced on such a small hole. And
interesting.
so they kind of, through some synthesis and analysis, broke it down into basically they thought they were going to do better because they had demonstrated improvement earlier, and the task was different or even changed. So like just improving their expected result, even if it's something that isn't necessarily related to what you're working on or their pathology. I think it brings in a little bit of that patient-centeredness that you talked about, and it just makes them feel better about their condition. It's like, oh, I'm not, like you were saying, I'm not totally broken. I'm not falling apart just yet.
No, that's great. I mean, I think, and that's where there's so many ways that we as clinicians can do that. The idea of, well, we could just be practicing picking up this kettlebell from the floor, but if we change the context of the scenario to picking up your granddaughter, now I'm already starting that perception of, okay, this task is meaningful and making it relevant towards the patient. But that idea also, like you mentioned with the putting, why beat the dead horse if you're failing repetitively and instilling frustration with that movement task and expecting failure? But if you just sort of set them up for success, does that have a greater carryover to their actual goals? It's great.
How how would you advise maybe new clinicians or clinicians who are going to, maybe listen to this and try and start adjusting their practice to kind of walk that line of navigating around some of those words, but also giving it to them straight? I know that was something that I struggled with on some of my clinicals, and I had a really great CI, Callie Griffin. I think she might have graduated with you or around the time you graduated. And she really helped me kind of figure out how to do that, because especially with some of our patients, so it was a outpatient neuro clinic, and some of our more central vestibular type issues, it's kind of a difficult conversation on how to word it so that you don't just say, well, your brain isn't interpreting things correctly, but also making sure that they understand kind of how we're going to work with them. And I had a few patients where I would explain it to them and like tried to go around it, and they'd come back the next day and they'd be like, yeah, I have no idea what you were saying yesterday. Like, I have no idea what's going on. So I guess how would you kind of advise newer clinicians and, even advice for myself on how to kind of walk that line and find that balance between using patient-friendly language and effective communication, but also just giving it to them straight?
I think one of those opportunities, if your clinic allows for it and if the patient allows for it too, recording yourself is an amazing, amazingly humble experience, especially from a treatment standpoint. We all have catchphrases. We all have small tics, whether that be saying, okay, good. And you're saying good after they have like 2+ out of 5, like knee extension strength. You're like, well, that's actually not very good, but that's your nervous response, right? Or how does that feel? That hurts. Okay, good. No, I'm pretty sure that's not a good scenario, right? So if you had the opportunity to record yourself, and I think doing it either weekly or quarterly or with some level of frequency, and then deconstructing that clinical experience and seeing what are the buzzwords that I utilize while I'm listening to this. Is there anything that makes me cringe? And that gives you an opportunity to not only try to succeed in the moment, but that self-reflection opportunity after you get a chance to write the note and see the patient and then really sort of deconstruct what words was I utilizing. I think that can be really valuable and a great learning experience. Because I think if you're trying to jump into this scenario of I gotta do better with my word choice and I'm going to start with a clean slate, it's really overwhelming. And the flow of the conversation does not go according to plan, the majority of the time at least. And so I would start there as a new graduate. That was one of those things that we tried to work on in fellowship. And I think that was really helpful. I had the opportunity to at least incorporate some of that guidance when I'm doing my mentoring with the residents currently, because their task is to make it through the evaluation and provide a successful clinical exam and potential home exercise program on that first appointment per se. And the one thing I might be focusing on would be what sort of reflections, what sort of patient first word choices or the ORs of motivational interviewing, and keeping track of that data while they're going through their examination. But if they were trying to do both at the same time, I think that becomes too daunting.
Yeah.
I'll never forget Jason Cherry mentoring me during a spine fellowship training. And Jason's sitting there with a clipboard. And I don't care how old you are or how many years of experience, if someone's mentoring or observing you to practice, there's some like heightened level of like, this kind of sucks. Like deep down inside, like you're thankful for the opportunity, but you're also like, I really wish I didn't need to do this at the moment. And so Jason's sitting there, and Jason's brilliant. And like, I don't even remember what the patient was. But all I know is that I'm talking and Jason's doing, and he's making like tally marks. And I'm like, I don't even know what I'm saying right now. And I look down and there's like 16 check marks in like one category, one check mark in the other one, none in the other two. And I'm like, I think I'm like failing. I have no idea what's going on. Yeah. He was tracking like how many reflections was I utilizing or open-ended questions as part of that motivational interviewing technique. Mm-hmm. And that was really eye-opening when I had the opportunity to hear from him what aspects of my word choice could be enhanced or modified. And you can do that if you videotape or record the session as well. So I think that would be a good starting point. I do also think picking one word as the word of the day to avoid can also be an interesting task. Mike Costello was my residency director, and I remember Mike saying, he would try to treat a patient in a specific position, or treat all the patients in sitting today. Like that would be his task. Like, I'm not going to treat anybody else, but just in sitting or lying down, or I'm not going to use manual therapy today. Just to force you to dive into that deeper level of either cognitive thinking or just clinical care. Mm-hmm. And so possibly another challenge that you could have would be, don't use the word pain with all your patients today. And so you're going to walk into that initial evaluation and you're going to say, on a scale of 0 to 10, and then you'd have to say, okay, well, what are your symptoms on a scale of 0 to 10? All right, you win, right? So you already succeeded. Or instead of using in all of your explanations for the why, you're not allowed to use arthritis, right? That might be the word for the week. Mm-hmm. Right? So don't use the word arthritis. How can you also provide that same level of education? So that's where you have chronological tissue changes, right? You have tissue that's currently sensitized from an increase in load, right? Its load tolerance isn't where you want it to be. And so you find different buzzwords that you can try to incorporate within those different words that you might utilize on a regular basis that might not necessarily be patient first, or might be more fear inducing, or might prevent you from having the flow that you want. So I think those would be probably two not overly daunting things that I'd probably try to start with as a new grad.
Yeah, I love those suggestions. I know when I was on my third rotation with Callie, especially towards the end, as I started to get more independent with care, she kind of played that mentor role and she'd kind of stand off to the side and she'd be typing up notes. And she gave a ton of feedback. After every patient, we'd kind of have a quick debrief, and then she'd give written feedback at the end of the day too. And obviously, now in the residency, after our mentor sessions, we have a full half-hour debrief, and then they send out email feedback. And before we go into a session, we get to kind of ask them to, I really want you to try and focus on this part of what I'm working on today. And I really enjoy that because I like the written feedback, because then I can, and kind of like what you were saying with the recording, is I can go home at the end of the day, decompress, and then I can sit down and look at it and be like, okay, how can I take what I have written here and make it change what I'm going to do tomorrow?
Right.
So I love that idea, and I think I might ask if I can record my audio of my sessions, because I think that'll be a good, reflecting, and then trying to build off of that is the best way to learn, at least in my opinion.
And I think that's where you have the opportunity to objectively track progress. How many ums did I say? How many times did I use this buzzword? 6 months later, where am I at? Or do you record yourself with a similar diagnosis, right? Do you have a patient from an orthopedic standpoint with patellofemoral pain syndrome, and you record on day 1, and then 6 months later you have a patient with patellofemoral pain syndrome, and you record the same thing? And do you compare and contrast? How did I communicate one way versus the other? What did I like? What did I not like? And did I try to actually make the change to become a better clinician either from an examination standpoint or just from a verbal standpoint as well?
Yeah, no, I think that's great too. And like you were saying, especially as a new grad, or if you're in a residency program or wherever you're working, you're focusing on making sure you're getting your exam or doing your treatment, and you're not missing anything. And there's just not time and cognitive processing power to also be taking note on those other things. So I think the recording is
and I think that's where there's different aspects of becoming that expert clinician that we all hope and aspire to become.
Mm-hmm.
And I think taking on so many different things at once, it takes away from the quality of the other components, right? So before you can be mindful about your word choice, you better ask all the right questions, right? You better perform all the right tests, and you better be able to provide the appropriate sort of education to the patient regarding the diagnosis.
Right.
And sometimes I know I'm guilty of it with our new graduates, and I'm like coming in like, what's the one thing I can contribute to these patients or to these new clinicians? It's like, well, here's some word choice stuff, and I'm sprinkling in this information. And I think at times it becomes kind of daunting, because then in the back of their mind, they're afraid to use what would be their typical word choice, and that throws off their flow. Mm-hmm. And so I do think that idea of sort of taking it one day at a time or one aspect at a time and not trying to do too much, become that clinician, perfect all your skills, and then just polish it. And that's where I think that's what fellowship did for me. Was I had my entry-level doctorate degree. I learned 5 years of clinical experience worth in a year with residency. And then I took that sort of roughened clinician that I was, and I had 2 years to try to perfect that. Mm-hmm. And so that's how I would perceive it. So.
Yeah, that's I know at the hospital I'm at, obviously I literally have been in practice for a month and a half now.
Yeah, hot minute.
So they kind of took that same approach. In the first couple of weeks, it was pretty much gen med floors, and it was like, figure out your system, figure out where to go, like how to get to the floor and how to use the system, and now we're getting into the other aspects of the residency more with the neuro populations, because our systems are down. And I try to be conscious of my word choice, but I think that's going to have to be an after residency directive for me. just because I'm trying to pull all these concepts in. And sometimes at the end of the day, I'm like, I don't even know what I did today. My mind was just going too fast. But yeah, kind of the brainchild for this discussion was Tim just had an article get approved for publication, The Power of Words. We'll link it down below. And it's a great article. It's not, a million pages long, so it's a quick read, but it has a lot of good clinical points in there, and it kind of has some options for alternative word choices to avoid some of those maybe trigger words like pain or arthritis or stenosis or bone on bone. I don't know. That's like a big one. I can't say how many times I hear people say bone on bone.
Yeah, and I think that's where you mentioned before that idea of the threat versus the challenge, right? And when has bone on bone not been a threat? Right? Or when has degenerative disc disease not been just a threat itself? And do you potentially be the person that implements it as a challenge, right? Now we got to get synovial fluid pumping, right? That motion is lotion concept. So we got to get you moving and change that from this is the perpetual decline to the end to I have an opportunity to actually do something about this. So yeah, bone on bone. That's definitely a bad one. So
yeah, and I think that, and we've kind of touched on this a little bit, that just as physical, we have so much time one-on-one with our patients as physical therapists, and a lot of face time, and we really in a lot of patients' eyes might represent the healthcare system as a whole, just because we do get so much face time with patients. It's not we're not a PCP where you come in for your checkup and then they maybe prescribe meds or refer you out to a specialist. And I think our ability to kind of change their perception, we're in a good position to be able to do that because we do get so much time with patients. So I think this is something that as a profession is maybe not more important, but we have a stronger ability to impact than other healthcare.
Definitely, and I think that's the cross that we have to bear, right? I mean, it's a blessing and it's a curse, and that's where we do have the opportunity to change patients' lives. Yeah. And we'll hear patients say, and everybody's going to hear it at some point in time, so many other people have worked on this, but you're the first person that's actually been able to fix it, right? And it's not necessarily because those other individuals didn't have the knowledge or they didn't have the skill set, because a lot of times they're seeing clinicians or practitioners that have so many more years of experience than we might have. But are you the first person that's listened to that person, right? Are you the first person that's educated them in a different way, or potentially not instilled fear associated with the pathology, and give them that glimmer of hope? And so I do think it is a tool in our toolbox, metaphorically, that we can utilize, and at times is underutilized, but has the potential to make a world of difference. So,
all right. If there was one thing you would advise anybody listening to this to do within the next week to consider the power of words or implement into their practice, one thing in 1 week, what would it be?
I'd say if Monday morning you had a 7 a.m. patient and you had a full day schedule, I would say slow down and reflect upon what is coming out of your mouth after you say it. Don't necessarily try to change the words just yet. Don't play the one word I'm going to change today game. Continue on as you typically are, but really reflect on what we're saying, because we do have those buzzwords or buzz phrases, whether that is bone on bone or pain and all this other stuff. But if you have the opportunity to see, okay, I just utilize that sentence again, or I don't really think about when I'm getting ready to say that, it just comes off the tip of my tongue. I think that in itself, just becoming mindfully aware of the words you're currently utilizing, don't try to change them, just become aware of them. That should sort of form the framework for you to go forth and make changes, subsequent patients, subsequent weeks, subsequent years of being a clinician. And so slow down, be more mindful, and reflect. And if you can do that, then you're setting a path for success.
All right. Well, you heard it. You heard it here. That's your action plan for this week. Slow down, take a deep breath, reflect on what you're saying, and then you can go from there. Tim, I thank you, and I appreciate you coming on and being our first guest on the Beer and a Thought podcast video series. I'm not quite sure what it's going to turn into yet, and I'm glad you were able to come on. And I thank you for your expertise and practice, and keep crushing it.
Yeah, man. No, this is great. Really excited for what you're doing. I think this is awesome.
All right. Thank you.
All right.